I'd like to introduce the next America's Frontline Doctors physician, my friend, Dr. Richard Urso. Dr. Urso graduated from the University of Texas Houston School of Medicine with the highest honors. He completed a residency in ophthalmology and fellowships, in 2 different fellowships. He joined the University of Texas and led the ocular trauma team at both Herman Hospital and LBJ Hospital for more than a decade. Dr. Urso.
Thank you. I have some slides, and well, it's some real sobering news. And as you know, we're supposed to be in this room with these, and we know what we think about these. You know, our voices should not be masked. Doesn't make any sense. So I want to tell everybody, we do live in the United States. We are we the people. We are a free country, and there's no reason we should be wearing these. With that, wow, that's sobering news. I think our academia, our NIH, our CDC, all our major journals are basically being influenced by monetary things that are basically causing them to basically censor information, not let information be known to people. And I think that's why I chose this title. It's about the silence, because they want us to be silent. They don't want us to speak up. I've been dealing with this since March when I first realized that there were lots of medicine for this. And as Dr. And I have a great message, by the way. I'm kind of excited to deliver this. It's not as sobering as what Dr. Todaro just talked about. But basically that we have early treatment. We do. We know that. And we knew it in March. And I'm really glad that we're kind of bringing that message to everyone. If you get sick or if you want prophylaxis, there's lots of things we can do. And I think that's something we need to keep bringing that message. But what we're going to talk about today is some of the testing and how it relates to a couple of different factors. And we're going to talk more, we're going to try to emphasize science and not science fiction. Okay, we're going to try to talk about a free exchange of ideas and not censorship. And we're going to talk about sense, not nonsense. So we're talking about PCR first. Let's discuss that, because this is what they're critically using to keep us locked down, keep us quarantined, is they're using this test, the PCR test. And basically you take a little piece of RNA, it gets transferred to reverse transcriptase, turns it into DNA, and then basically they get some fragments and get us whether or not we have a positive test or not. We don't know when we do it on whether or not we have a little fragment like this, or whether or not we have a whole fragment. So you can be PCR positive with a little fragment or a big fragment. And so what happens is, as you do this test, each time you do a cycle, you get a doubling. So by the time we get to 20 cycles, we have 1,000,000 pieces. When we get to 30, we have 1 billion pieces. And when we get to 40, we have 1 trillion pieces. Okay, that's actually true. Those are the numbers. Okay? So when we get these cycle rates going up to 40, we see a lot of false positives. And it's allowed, the CDC and I think allows up to 40 cycles. So basically, there's a lot of problems when you get up that high. You're basically looking at tiny little fragments, and there's lots of issues with that. So some of the things that can happen with any test, there's false negatives. The test isn't done properly, mishandling of the swab, and as we talked about, what about the false positives? Well, what they're looking for here is they're looking at the N-terminal domain, and that's usually what they're targeting. So the proprietary technology is not really something that we have easy access to, but for the most part, they're looking at the N-terminal domain, which is part of the part that binds to the actual ACE2 receptor. So that's lastly, I want to talk a little bit about PCR versus serology. Just a quick thing about this is that serology is the antibodies that come after you've been infected. And the reason I want to bring it up, because in Texas, they were actually using this in order to actually keep us locked down. People who were coming back PCR positive were locked down, but people who were coming up with positive serology, who already had infection, IgG and IgM antibodies, they were actually being locked down. They had a quarantine. That doesn't make any sense. It means they had the infection, now they've mounted an immune response, and those people had to then quarantine for 14 days. Eventually, they finally figured out that that's our health department, figured out that how these things work. It should have been known right off the bat, but somehow they didn't figure that out. But, next slide. So one of the things we want to find out with PCR is who's infected. Is it PCR positive people? Are they all infected? Who's infectious? Are asymptomatic people infectious? Are symptomatic people infectious? And who's susceptible? Is it everyone? And these animal pictures up here are because the president of Tanzania didn't trust the PCR. So he swabbed a goat, a quail, and a pawpaw, and they all came up positive. So one of the myths is you're infectious until you're PCR negative. So let's talk about that. So most viral disorders, like viral conjunctivitis, you're infectious for the first 5 to 7 days. And after that, the second week, you're probably not infectious. We see the same thing with COVID. For the most part, that first week, you're likely to be infectious if you're carrying large amounts of virus, but not so much in the second week. And so we have a hard time after day 8 to culture virus. So first week, high chance of being infectious. Second week, there's a lot of inflammation, but you're probably not infectious. And then the cycle threshold, as I said, once you get over a certain number, and what they're allowing is up to 40, there's somewhere, and you won't believe this number, I think you're going to have a hard time believing it, but up to 70 to 90% of these people are what we call false positives. They have little fragments of the virus that are not infectious, okay? And they're becoming PCR positive. They have to quarantine, they have to lock down, they have contact tracing. It's very expensive, and this is what we're doing in our country. This is how we're keeping this whole thing going. So the New York Times actually had came out and said that we had 70 to 90% false positives. We talk about the mainstream media being complicit in this. Sometimes these articles slip through. That's truth. Once we get above 24, okay, these are numbers. Once we get above 24, there's almost no chance of culturing the virus. But what they're allowing is basically numbers up to 40, which means a lot of them are false positives. And it's used to be justified the lockdowns, the quarantines. So is this appropriate? Well, let's think about it. Asymptomatic transmission, is it a major driver of the epidemic? Well, let's see what Dr. Fauci has to say about it.
Etc. But the one thing historically people need to realize that even if there is some asymptomatic transmission, in all the history of respiratory-borne viruses of any type, asymptomatic transmission has never been the driver of outbreaks. The driver of outbreaks is always a symptomatic person. Even if there's a rare asymptomatic person that might transmit, an epidemic is not driven by asymptomatic carriers.
Thank you, Dr. Fauci. True. So what we're seeing is they're not driving the epidemic. Why are we testing them? Why are we chasing them all down? Why are we contact tracing these people? It makes no sense. We're literally wasting money, wasting time, scaring people. That's all we're doing. Next slide. So let's in tracking cases, again, we're hunting. Should we be tracking people that are asymptomatic? Because I don't know if you guys know, but contact tracing is really expensive. In Texas alone, we have $300 million earmarked for contact tracing. And does it make sense to contact trace asymptomatic people? Or should we isolate the symptomatic and protect the at-risk? Let's see what Dr. Van Kerkhoff has to say about that from the WHO. She's the lead COVID person on there.
What we really want to be focused on is following the symptomatic cases. If we followed all of the symptomatic cases, because we know that this is a respiratory pathogen, it passes from an individual through infectious droplets. If we actually followed all of the symptomatic cases, isolated those cases, followed the contacts and quarantined those contacts, we would drastically reduce. I would love to be able to give a proportion of how much transmission we would actually stop, but it would be a drastic reduction in transmission. If we could focus on that, I think we would do very, very well in terms of suppressing transmission. But from the data we have, it still seems to be rare that an asymptomatic person actually transmits onward to a secondary individual.
So, you heard it again. Asymptomatic people rarely transmit the disease. Okay, we were taught that in medical school. It's never changed. does somebody think that there's one virus, a brand new virus, all of a sudden changed the whole thing? And actually, you've heard it now from 2 people that are basically considered leaders in this area, that this is the way it is the way it is for this disease, this is the way it's always been. And so why are we wasting so much money chasing down these PCR tests on asymptomatic people, contact tracing them, doing things that basically waste a lot of money and create a lot of fear in our population? So let's think about whether or not, let's slide. Does contact tracing significantly reduce disease spread? Well, as I said, it's costly, okay? But I think personally what we're seeing here is a big violation of civil liberties. This is the United States. People aren't going to tell on their neighbor here, and that's basically what happens. Hey, they know that if you contact trace somebody and they say you were exposed, you have to then quarantine, even though you may not be symptomatic. How much sense does that make? We just heard, if you're not symptomatic and you're contact tracing somebody, you're going to lock them down. That is a violation, and you haven't even helped anything. You haven't even stopped any disease spread. So let's hear what Dr. Van Kerkhove has to say about contact tracing and who should get it.
We have a number of reports from countries who are doing very detailed contact tracing. They're following asymptomatic cases, they're following contacts, and they're not finding secondary transmission onward. It's very rare. And much of that is not published in the literature.
I wonder why. Why didn't it get published? Why didn't it get published? That's big news. We shouldn't be doing this. They still haven't published it. This is months ago. None of that's published. And it's still true. So what we're seeing is that these contact tracing was designed more for like a norovirus outbreak or maybe a measles outbreak or potentially a polio vaccine gone bad or something. They were designed for small, isolated instances. That's what they were designed for, not for contact tracing the entire world. So that's a real silly thing to do. And lastly, I just wanted to make a comment about some of the isolated populations and what we're seeing here. And I have a concept that I think I couldn't come with all the detail on this, but conceptually what I found after I looked at all the data was that the asymptomatic people, all right, they weren't spreading disease. And in fact, it appeared that asymptomatic people were spreading immunity. When you have those tiny little fragments, you're coughing a vaccine on people. That's what we see. That's a fundamentally different thing. Asymptomatic people are spreading immunity. Think about that. Next slide. So this is kind of changing gears. And we all know that back in February, COVID was going to kill us all. Right? We clearly know that that's not true. And we know that certain populations are incredibly rare to die. Let me hear what Dr. Redfield has to say about the younger population.
And I think that's important because what that means actually is the risk per 100,000 so far, into the outbreak, 6 months into it, is in fact that we're looking at about 0.1 per 100,000. So another way to say that it's 1 in a million. Now, I'm not trying to belittle that. I'm just trying to make sure we look at it proportional, because if you do the same thing for influenza deaths for school-age children over the last 5 years, they're anywhere from 5 to 10 times greater. So I want people to understand the risk properly as they make that decision.
Thank you, Dr. Redfield. That's great. What we're finding there is that we're hearing that it's okay for kids to go back to school. Okay, we just heard that. Okay, think about that. Flu is 5 to 10 times, according to him. I would say it's probably more along 4 times, but 5 to 10 times higher, according to him. He's got a lot of data sitting in front of him, so there's probably some truth to that. So how can we close our schools with that kind of data? Look at the case fatality rates. Until you get over 70, you really have better case fatality rates here than you do in the flu. So we never locked down for the flu, and we're going to lock down for this disease. And again, I never thought it made sense, and that's without early treatment. Imagine if we'd actually started treating early. Imagine what our numbers would look like. And just to go through a few things, I want to bring this out for the audience. In Sweden, 1.8 million kids under age 15, not a single death. 0. In the U.S., you see the elderly people are accounting for most of the deaths in the U.S. and Italy and in Sweden for that matter. So our elderly are most at risk. And what about comorbidities? As you know, comorbidities matter. 2 or more comorbidities accounts for 94% of the deaths. So I think it's basically 5 to 6% worldwide, not just in the United States, have no comorbidities. All right, so let's get to the best news. Okay, next slide. So what we see here is these pandemics have happened before. Let's look at some of the major pandemics, okay? And what you've got here is 1918, 1957. You've got this early large hump, and then they're always the same, about 110 days later, followed by a small hump. Isn't that interesting how that happens? So as disease spreads in communities, it hits the most susceptible, the larger populations first, and you get this huge hump. And as the susceptible population decreases, and as you get into smaller communities, you get a second smaller hump. And you see it here in the middle slide. That's our current day pattern. Large hump, about 110 days later, small hump. We're on the back side, okay? So is the pandemic going to go on forever? What's the history show? History shows we're probably done. We're on the second hump on the back side. And what do we have? Okay, let's go to the next slide. What do we have right now? What do we have? How are we keeping this? How are we fueling this? How are we feeling this? How are we feeling the fear? We're PCR. We're doing PCR. We're testing asymptomatic people. We're testing too many people. And so we're driving this case-demic. We don't have a pandemic anymore. The pandemic's over. If you look on the slide, the red is the people that are dying. And you see like in Spain and Netherlands just locked down again. They just locked down again. So that's why I chose them. They had a big pandemic with lots of cases, and you see that's back in like April, and same thing in Spain. And now they've got a case-demic. They just tested a lot of people. There's nobody dying. Very few people are dying. So I think it's really exciting news to know that the PCR test is actually what's driving this case-demic. This is courtesy a little bit, if you guys have ever heard of Ivor Cummins. He's actually put a lot of work out into this, if anybody wants to hear more about it. But we have a case-demic. The pandemic is over. Thank you.
Thank you so much, Dr. Urso. I always learn a lot when I listen with you. If we can just recap just 3 points for the American people. So what you're saying about testing, just the PCR is a type of test that we use, right? And you're saying that the PCR test can be so sensitive that it's just picking up little fragments of RNA that really are not meaningful to a physician or a patient?
Correct. The fragments are so small, they're not infectious. They're identifiable as being the virus or something close to the virus. And let me just make a little caveat about that. On chromosome 8 of our own, if you have such a small fragment, our own chromosome 8 matches up quite well with the portion of the coronavirus. You may be just looking at chromosome 8 on the human body.
So this is why you use the phrase case-demic and not pandemic, is because we're having all these things that positive numbers, those are cases. It's different than an illness, it's just a case.
Correct.
Yeah, that's very, very important information. Another point that you made that I had actually forgotten about was the lady from the who said that asymptomatic transmission is not a driver, and of course Dr. Fauci also said it's not a driver of illness. Do you know what happened with her? Why haven't we heard about that video? What happened with her after?
Well, she came back and she actually they kind of made her come back and actually talked a little bit more, but she basically doubled down. She said the same thing over. She just said it slightly more gently. She didn't use the word rare. Basically, she couldn't, she has too much integrity to actually go back on her word, unlike Fauci.
Right,
Sorry.
so this is an example of, the disinformation, misinformation, censorship that people who are trying to bring the truth to the American people are facing. Here she was, she brought this truth, it's very clear what she said, it's not ambiguous. Interesting. And then Dr. Redfield, who was talking about the risk to the younger population. So again, just so your impression as a clinician, somebody on the front lines, in terms of the young people, it seems very clear to me what he said, that in terms of young people, the risk is actually a fraction of what it is for influenza. Was that your understanding?
That's correct, and I think that all the data shows that. It's a fraction of what influenza is, up until probably about age 70.
Thank you so much, Dr. Urso.